Hi, everybody. Thank you so much for joining us this evening for our adolescent health slash chapter town hall. Um, I'm pleased to bring you another round of our sex, drugs, and rock and roll adolescent health lecture series. Just given the season, I'm sure lots of people are seeing kids for sports physicals and pre-participation evaluations in their offices this time of year. And so we thought that we would have an evening seminar dedicated to um, updates in the pre-participation evaluation for teenagers. I am very happy to be joined by some friends. John, could you advance slides, please? After I kick us off, we're going to have Dr. Marcia Spitzer from Family Health Centers of San Diego providing some updates on guidelines for performing comprehensive and effective pre-participation evaluations. And then Dr. Preetha Dalal from Rehab Medicine at Rady Children's Hospital is going to provide us with some updates on concussion management, always a hot topic. And then I'm going to finish us off before the Q&A with weird sports nutrition trends and how to separate fact from fiction and give some talking points for counseling parents and caregivers and kids. Next slide, please. So I'm going to begin by introducing my colleagues. Many of you probably already know Dr. Spitzer, who is a past president of the AEP and in our local chapter. She's been working at Family Health Centers in general pediatrics since 2001 and is currently the chief of peds for clinical support, working closely with the clinic operations team to optimize best practices as more than 10 primary care sites and newborn hospital services. She's currently still the Reach Out and Read San Diego medical director, and she previously cared for young people and supervised residents at Family Health Center's teen clinic. And then Dr. Dalal is a physician in the rehabilitation medicine department at Rady Children's for the last 10 years. And she is the director of the concussion clinic and the chronic pain physician at Rady Children's. And I'm not going to go over my introduction other than that I have the honor of being the chair of the Adolescent Health Committee, and I do a lot of work with eating disorders and disordered eating, which has a lot of overlap with sports and sports nutrition. So I'm really excited about tonight's talk to learn and to get some good discussion going. So with that, I'm going to kick it off to Dr. Spitzer, who's going to be starting us off with updates on the PPE. Take it away.
Great, thanks, Maya. Let me get the slides up. All right. So thank you, everyone, for spending some of your presidential debate evening with us here at AAP. And I know most of us have done, if not many, at least some adolescent pre-participation exams. So what I'm not going to cover is how to do a PPE, because we're all pretty good at it. What I'm going to try and hit on are some of the tips or changes that have happened over the last few years to help you be kind of up to date and feel real comfortable with what the PPE form is. Yeah. So I have nothing to disclose. Although the one thing I will disclose is I'm a general pediatrician. I am not a sports medicine specialist. And so I approach this as a general pediatrician, and hopefully that will lead to some robust discussion at the end with questions that we can talk about. So why do we even do PPE? So really the main goal is to prevent disease and prevent injury in our adolescent athletes. So we're screening for high-risk conditions that may affect the athletes' participation in sports. We're ensuring that kids with higher risk conditions are still able to play in a safe manner. And then we want to make sure that all of our patients are healthy and ready for participation in athletics. But we do more than just that, right? Many of us know this may be the only time we see this youth in the entire year in our office is when they need that sports physical. So we really want to capitalize on that and use that opportunity to obviously provide the sports PPE, but if we're able to do any of the other things they might need that year if we have not already seen them. That may include doing a heads exam, opportunity to give immunizations, talk about other chronic medical conditions they might have. So the good thing is that we have this opportunity to see all these kids and see them at a moment where they need something from us. So they're definitely going to come in, but also be able to cover a lot of these other issues. Now, one of the harder things can be that a lot of insurance companies won't even pay for a second physical during the year. So it may be that it's a child who had a physical earlier and they need a sports physical, and a lot of insurers may not pay for a second sports physical. So it's really, if you think that child's going to do sports at all when you're seeing them for their regular physical, if you are able to, it's nice to be able to do some of the additional cardiac screening questions, some of the additional exam that you might do in case that kid really does want to come back, but it's hard to find a way for them in. Um, and as part of that, one of the questions that actually was submitted ahead of time is like, why is CIF and why are the school districts so sticky about that? The physical must be done June 1st or later of the previous year, right? Because if a student athlete has had a physical, let's say in April or May, and then they want to play volleyball in the fall, a lot of the school districts will say, no, it has to be after June 1st for their physical. So then sort of in this dilemma, like, what do you do with that patient? And so the reasoning for this is mainly that schools want to make sure that kids have sports physicals that are valid for an entire year. So since school lets out by the end of May now in San Diego, if they know if a child has a physical June 1st or later, then they have 12 months of eligibility with that physical that will cover the entire school year. Now, obviously, there's times where maybe a child only plays a fall sport. So it doesn't really matter if they have spring eligibility. But the CIF, that's sort of their blanket. And I actually talked to Howard Terrace, who many of you guys know, he's the medical consultant for San Diego County Schools. And I asked him as well, and he said a lot of this, it's driven by CIF. And until CIF makes a change there, we're really kind of still in that June 1st pattern. It's not every district interest, but certainly San Diego Unified is one that does this. So what's new on the PPE forms? So really the big change from the previous versions of these is what I highlighted in yellow at the top. It says this form should be placed into the athlete's medical file and should not be shared with schools or sports organizations. So this is on the questionnaire or history form. It's also on the exam form. And you can see some of the stuff I highlighted below, some of the questions: sex assigned at birth, how do you identify your gender, maybe things that a student athlete may not have shared with their school. And so the reasoning for why the physical history form and the physical exam form are no longer mandated to submit to schools is because, unfortunately, there are parts of the country where gender identity, their pronouns, also things like their last menstrual period, if they're a menstruating adult or menstruating athlete, those things may be used in a way that is not safe for that student. So in parts of the country where birth control and reproductive rights, where gender affirming care are limited or even considered to be child abuse or illegal, the AAP really wanted to make sure that student athletes weren't putting their own care at risk by disclosing information that could be used against them and used against their families and against their physicians. So we work in San Diego, thankfully. This hasn't been a state level issue for us at all, but that's kind of the thought behind that. So it shows it on the top of the history form. It's on the top of the physical form. And then when you get to the last page, the pre-participation physical exam medical eligibility form, this is the only one that you have to submit, or that an athlete has to submit. And again, I went back to Dr. Terrace and I asked, well, how are you guys managing this? And what's the advice that you're giving to the different school districts? And his thought was, he still thinks that a lot of this should be shared with schools for two reasons. So one of which is that there may be things that impact a student's participation in sports that may be confidential and yet also important to that athlete's health. And so, for example, if you have an athlete who's pregnant, for example, right, that's definitely something that can impact that athlete's health, but is also potentially something that that athlete does not want to disclose to the rest of the school or the rest of the school's administration and their files. So one thing he did tell me was that these forms are not seen by everyone in the file. So much like we have HIPAA right? And you're only supposed to look in the chart and only look at the information that you need to provide care for that patient. Schools have the same thing. So his take on this was that most of these forms, well, all of them should be in the file, and really the only people who should be able to access them are the school nurse and the athletic trainer. So even individual coaches do not have access to the athlete's history or physical forms. He did also caution that if you prefer, or the athlete prefers to only submit the medical eligibility form to the school, if you have caveats, restrictions, something else, recommendations, to be very clear about them. Because he said, for them, it's hard sometimes to get a form that just says reduced activity or non-contact sports, and it's helpful for them to have a little more context. So he said, if a student has a condition and they really don't want to disclose that to the school, that it might impact their participation in sports, the right thing to do is to write down just very specifics what that athlete can and cannot do. You don't have to say why, but you just have to say what the restrictions might be. So that takes me to my first point about confidentiality. So for every office, you just want to have an idea of what you're going to do if a student athlete has a confidential topic that they want to discuss or that comes out as part of the visit, and it's part of a sports physical. So a category of a visit is not typically thought of as like a part with a confidential component. What to do if a patient shares that confidential piece of information? Do you need to put that on their pre-participation exam? Is it not relevant to the pre-participation exam? How are you going to manage that in the chart? And how are you going to do the appropriate care, the feedback? And again, as I mentioned, Dr. Tara's suggestion was that you only mention things that are going to impact the student's participation and be very specific about what kind of restrictions they might have. All right, so tip number 2, and the only other big change to the pre-participation exam form is about COVID, right? So the current AAP guidance is the guidance from September 2022. It has not changed. Or really, if you have an athlete who has had COVID recently, how you manage getting them back into sports. So there's really 3 categories. If they've had asymptomatic mild infection, it's defined as fever for less than 4 days, symptoms for less than a week. You can do a phone follow-up or a telehealth follow-up, and that's it. If they've had moderate symptoms, so that's defined as more than 4 days of fever or more than a week of symptoms, but no ICU admission, no MISC, you really should do an in-person evaluation, including cardiac exam, and you should consider doing an EKG. And then for those severely or severe COVID infections, so those are really students who went to the ICU or a student athlete who has MISC, that they have exercise restriction for a minimum of 3 to 6 months, and they really need to see cardiology prior to their return. And this is the same, but in an algorithm form for those of you who think more kind of visually. Okay, tip number 3, mono, right? We all learned, monosplenic rupture, got to do something about restricting from sports. So why do we care? So infectious mononucleosis, right, can cause splenomegaly and splenic rupture during and right after infection. So we should be able to identify who has splenomegaly and see whether we can clear those athletes. Right? And the hard part here is that the physical exam for splenomegaly is not very reliable. Abdominal ultrasound is also not very reliable. So really the safest thing to do if you're working with an athlete who's had mononucleosis is that they should have 3 to 4 weeks of complete exercise restriction, knowing that some of those kids do not have splenomegaly, but we just don't know when it's the safest approach to take. All right, so skin infections. So in general, most skin conditions and most skin infections are not an issue for sport participation, but they are for those sports with close contact. So think wrestling, think boxing, think martial arts. So tip number 4, what do you do with the athlete who has either impetigo or MRSA now, or has chronic recurrent symptoms? So when you're clearing them for immediate sports participation, they have to have had no new lesions for 48 hours, have completed 72 hours of antibiotics, and nothing moist or draining. And if they're an athlete who gets frequent recurrences of impetigo or MRSA, especially during the sports season, you may want to do some of these elimination strategies that we use for kids with recurrent MRSA, doing the bleach fast or chlorhexidine twice a week, making sure that you're washing all of their sports equipments, their pad, their towels, their uniforms, anything like that that they might wear that has contact with the skin, and then that's daily, and then cleaning any contaminated surface. So tip 5 is, what do you do with the athlete either with herpes right now or recurrent herpes lesions? So again, they can return to sports, and this is mostly for your athletes with close skin to skin contact, right? They can return to sports when their lesions are all crusted, no new or active lesions, and they've taken at least 5 days of oral antiretrovirals. And for athletes who have recurrences, especially during the sports season, you might want to consider putting them on suppressive therapy with antivirals for the entire season. So tip number 6, cardiac screening. And this is a big one for a lot of people, right? So every athlete should get a complete history and physical, of course. And then you want to think about additional evaluation for those athletes with a history of syncope or chest pain with exercise, or a family history of cardiac death or sudden death before age 50. Now, the reality is, unfortunately, most cases of sudden cardiac death occur in patients who do have no pre-existing cardiovascular history. We do know that universal EKG screenings are not evidence-based. That doesn't mean that can't be helpful for the individual athlete. There's no evidence to support that every athlete needs a pre-participation EKG. What the American Heart Association recommends is this 14-element cardiovascular screen that includes history, family history, and physical exam that I've got copied here. And then how about specific cardiac conditions? So we know that patients with stage 2 hypertension should be excluded from their high static sports until their blood pressure is in their normal range. And high static sports are those ones that you think of like youth alpha, right? Wrestling, gymnastics, weight training, weightlifting, those kind of sports. We also know that certain high-risk cardiac conditions, you may need to make modifications. And again, most of these are going to be in concert with the patient's cardiologist. So hypertrophic cardiomyopathy really should not be doing severe intensity activity. Patients with anomalous aortic origin of the coronary artery should not do competitive sports until at least 3 months after their surgical repair. And myocarditis, also no competitive sports for 3 to 6 months until cleared by a cardiologist. So tip number 7, asthma and kids with a history of anaphylaxis. I think this is one of these things we don't think about a whole lot with athletes, but when you just think about the frequency and the incidence and the prevalence of asthma in kids who carry EpiPens, this is actually a really great opportunity to make sure our adolescent athletes have what they need at their side when they need it. So a lot of kids may have an asthma inhaler, an asthma action plan on file in the school nurse's office, which is incredibly important. But most sports practices do not take place right next to the nurse's office. Most nurses' offices close after school. And so that isn't available if the athlete's got practice after school, practice before school. And also a lot of athletes are traveling to other schools for games. So you really want to make sure that your athlete with asthma or a history of anaphylaxis has an inhaler, has EpiPens that they are carrying with them when they participate in sports, not just in the nurse's office. And then they have their asthma action plan or their anaphylaxis plan. And as all of you guys know, there is a space on the asthma action plan where you can say that in your opinion, the athlete can manage using their inhaler. And obviously for most of our high school athletes, that should be the right answer. We also want to be sure that their coach or trainer knows that they have a history of asthma or anaphylaxis so that they're prepared in the instance that a student needs assistance on the field or during a game or during travel to another site for a game. Tip number 8, vision, right? So the highest risk for eye injury, the highest risk sports are basketball, combat sports, baseball, ice hockey, which you don't see so much in San Diego, and lacrosse. The recommendation for eye protection is ASTM approved polycarbonate lenses. I have a bunch of different options here that I have pictures of. Really for all athletes, the recommendation is that they use protective eye gear for high risk sports, eye contact, and for functionally one-eyed athletes. And that's defined is the athlete's vision is such that the better of the two eyes cannot be corrected better than 20/40. So that's actually a lot of our athletes. The recommendation is that they avoid high-risk sports and that they should really wear protective eye gear for all sports. And that information I'm taking from the American Academy of Ophthalmology, and I've got their website here. They also have some good very sports specific information for families. So tip number 9, we're talking about high contact sports. What are the high contact sports, right? So here's the list here. I'm obviously the ones you see a lot of in San Diego: basketball, football, lacrosse, martial arts, and soccer, water polo. Some of these you don't see quite as much in San Diego: ski jumping, ice hockey, but it's good to know which are the sports that are considered the high contact sports. And the final tip number 10, this actually comes from a question Dr. Kumar asked me to cover, which is, why do we do a male GU exam as part of the sports PPE, but there's no place where we're supposed to do a female? So really the single organs, so for our paired organs like testicles, ovaries, eyes, you really want to know if the athlete only has one of those two, right? And so absence of a testicle or an ovary increases your risk again with those higher contact sports. If you only have one of the two, you want to make sure that you're protecting the one you have. So patients with testicles, we can do that exam in the office. You do a testicular exam, you know whether or not they're there. Patients with ovaries, there's no easy way to do that, right? So we're not going to be doing pelvic ultrasounds, pelvic exams to determine whether or not there's one or two ovaries. So the reality is we do the male one because we can do it as part of an exam, but not for our patients with ovaries. Inguinal hernia screening is actually not required and not necessarily recommended as something that needs to be part of the exam. And I'm just going to close by saying, for all of our adolescent patients, if we're performing a GU or a sensitive exam, we must offer a chaperone to the patient. And if the patient declines the chaperone, we definitely want to have another adult in the room. Often that's the parent or the guardian. And we want to document appropriately that we have that second adult in the room. I'm going to end there. These are my resources. I just want to say thank you to Tim Dwyer, who's one of our pediatric sports medicine docs here at Kaiser, and Dr. Howard Terrace here in San Diego, who is our medical consultant to our San Diego schools, for their input. And then I also have most of this as information from where I took this information, rather, as links. And that is that. Thank you.
Thank you, Dr. Spitzer. That was fantastic. I really appreciated the top 10 summary. I'm going to pass it on now to Dr. Dalal, who's going to be talking to us about updates in concussion management.
Let me share my screen and I will get started. Okay. So I will try to keep things quick. I'm going to start with updates. I think, as Dr. Spitzer said, you all have seen patients with concussions, so I'm not going to go through all the details with it. But
I'm sorry to interrupt, Dr. Dalal, but your slides are not the full slide.
Oh, no.
So maybe unshare and share again?
Sure.
Sorry to interrupt.
No worries. Let me try that again. Oh. Okay, let me try it this way. Is that better?
Yes.
Okay, sorry about that. So I'm just going to go through the updates in concussion. There was a conference that was held in 2022. The findings were published last summer, and that is kind of the big international concussion conference. And so that's where I'm going to be sharing these updates from. There are some new tools. There's an updated SCAT, which I think you might have heard of before, that has a lot of symptom assessments. It's kind of more of a sideline assessment tool for someone that's a medical professional. But they have added a SCOT, which is actually for medical professionals and doing this in the office, which they had not previously included. And so I'm going to go over that as well. And I'm going to switch screen share for a second to get to that. And there. Okay. Can you see that? I'm going to assume yes. Okay,
Yes.
perfect. So the SCOAT is an office assessment tool, and I completely recognize that you only have 15 minutes with the patient if they're on time to see them. So I do not expect primary care doctors to go through the entire SCOAT, but I thought it would be something that was good to kind of reference if you do have a more complex concussion, possibly before you were sending them to concussion clinic, or if you were bringing them back for a little bit longer visit, if that's even possible for you as primary care physicians. So it's really helpful in the sense that it kind of has everything that you need for a concussion in one place, kind of recognizing, and some of this hopefully, or you can kind of consider having the family fill out ahead of time, some information about when they were removed from play, when the injury was, some description. I'm going to kind of go through this part of it quickly because I think that this was, or this will be shared with you as well, just to go over kind of the more important points. There's a section for any important neurologic, psychologic, psychiatric disorders. And the reason why this is important is these are more likely to have prolonged symptoms. And so if you already know these are the case, if they're not improving relatively quickly, then you may want to consider kind of sending them to us as well. Current medications, family members with these diagnoses, depression, anxiety, ADHD, learning difficulties, or migraines is also important because those are also patients that might have prolonged symptoms. And then the symptom evaluation. So we've shared this before, kind of the symptoms of concussion. I will kind of skip through these just to get through the rest of the SCOAT. I think that some things that are helpful to kind of add to your assessment is, when do the symptoms worsen? Do they worsen with physical activity, cognitive activity? And those kind of help you decide how to progress a patient. And I'll get into that a little bit more. I think, to be totally honest, some of these cognitive tests, unless you're not sure what's going on, I feel like, truthfully, it's a lot to be doing in your initial clinic visit. I think that they're better on the sideline for someone that doesn't know them. But if you know your patient clinically and you know that they're, telling you that they feel off cognitively or physically in that initial concussion, I don't know if it's really worthwhile to do a lot of cognitive testing, especially in those initial visits. Sometimes if they're feeling back to their normal and you're not sure, I think that this is when these might be a little bit more useful. And then again, I'm skipping through so that we can, for the interest of time, and also to not reiterate some of the stuff that you already know. With patients, especially the ones that have had a syncopal event that leads to a concussion, or if they're complaining about dizziness or lightheadedness, it would be helpful to get a set of orthostatic vitals for the patient, so you kind of know. It also helps, again, closer to clearance, because if they're already having dizziness symptoms, again, right away, I think it's more important to kind of make sure that their orthostatics are back on track once they're back to normal. The things that I think do help guide your clinical care is a little bit more of that cervical spine assessment. And if I've ever talked to you, or you've ever heard from me about concussion in the past, I feel like this may be the one area that's kind of missed. It's just not something that we talk about as much just in general pediatrics. But it's an area that if there is a lot of neck pain, there's some recommendations of when to refer to physical therapy as well, which may help speed up recovery and speed up recovery from the concussion altogether. So I thought that was kind of helpful to have in there. And then lastly, you know how to do a neurologic exam. I'm not going to go over that. The BESS is a modified BESS is one that you are checking balance. And it's basically standing on both legs, standing on two legs together, or then standing on one leg. in your clinic visit, and you're basically looking for any losses of balance or kind of movement of that foot that is you're balancing on. There is another option that's a timed tandem gait. It depends on how much space you have in your clinic, because they recommend considering doing a 3-meter long line on the floor. And so depending on how long your hallway is, you could consider adding this to your assessment, especially if their balance is so bad that you just want to try to have them walk. And tandem gait is, remember, heel toe and heel toe. More complex items, and again, I think this is kind of later on in the concussion assessment, is if you're having them do activities while they're doing tandem gait. And then again, some of this is dual task gait items. And then I'm starting to get to the end. I know that's a lot. Again, it takes me more than 15 minutes to even talk about this, I feel like. Is just looking at ocular movements. Again, this is when, specifically when there's dizziness and nausea, it can be helpful to look for smooth pursuits, saccades, and I don't know how many offices actually have a metronome. We don't even have a metronome in our concussion clinic, but kind of just looking for eye movements between to see if you're noticing any abnormalities or increased symptoms. I think that this is really helpful when you're looking for return to learn, especially if they're having more difficulty with horizontal eye movements. You know that they're going to have difficulty with reading. So that's where it helps me. They include an anxiety screening, but you maybe already have an anxiety screening in your clinic that you use. They also include a depression screen as well, and some information about sleep. And then I'm toggling through for kind of, they have like a whole sleep score, but it's more just to kind of see if their sleep is off. And then back to some of the cognitive testing, it's delayed word recall, and then the graded aerobic exercise test. I do not expect you to be able to do this in your clinic as well, but I included all this to kind of let you know that there's a lot more included in the most recent assessment, and I think this is all just kind of general information. I'm going to go back to my slides really quickly, and then I'm going to go back to give you a little bit more information that came out of the most recent updates. Okay. This, I just needed to include this because that long paragraph on the bottom is what all of these experts came together to make the concussion definition as, which, as you can see, is ridiculous. But it is basically an injury caused by a direct blow to the head, neck, or body, resulting in a force transmitted to the brain. The important part of this is that CT or MRI is normal. And so that's the important part for you, in the sense that many times there's pressure to have an MRI in this setting. And I think that that's where I kind of bring this up, because if it is a concussion and you believe that they truly have a concussion based on their signs and symptoms, patients do not need an MRI. If there's something abnormal on their exam, if there's something that does not fit with a concussion, then that might be appropriate. And if there's questions more about that, we can go over that. As far as evidence to prevent concussion, so this is some of the stuff that came out of the study is, and I wanted to share this with you because I know that this is the questions that we get, is that limiting checking in ice hockey has shown to prevent concussion. Mouth guards in ice hockey have been shown to prevent concussion. A decrease in number and duration of contact practices during football practice has been shown to prevent concussion. And so I think that's really important for us to kind of continue to share with coaches. And I have been trying to do that a little bit more, but recognizing that they don't necessarily need to do contact practice during practice may actually prevent concussion. Neuromuscular training, I left the link in there. There's a series of exercises that are more balance-based and kind of core strengthening and also just movement-based that have been shown to actually decrease the incidence of concussion in athletes that go through these trainings. So I thought that was kind of important for me to be able to share with you. And then I also share this with families as well when they come into my clinics. And then appropriate concussion treatment actually is shown to prevent concussion as well. Some updates on rest. There is a...
I'm sorry again. Were you changing back to sharing your slides? They're not.
Oh my goodness. Did I not do that?
I'm sorry.
Ay, I'm so sorry. I feel like I'm doing all kinds of technical difficulties. All right, I'll go back. So that was the definition that I was talking about. I will skip ahead. So the updates on rest. Early return to physical activity as tolerated is what's recommended now. So I understand that there are going to be that subset of patients that really are struggling to return to physical activity and have a lot of symptoms, but those that don't have a lot of symptoms are encouraged to return to physical activity, but limiting and not doing contact activity. And so I will get into this in a little bit, but I wanted to bring this other point up, is that the evidence doesn't really show that decreasing screen time after the first 48 hours necessarily helps unless they're having a lot of light sensitivity and their symptoms are significantly exacerbated by screen time. The goal is to advance intensity of activity depending on the degree of symptom exacerbation. So the data is that on days 2 to 10, the goal is to increase activity that is below threshold for increasing symptoms. And their definition of this was, as long as it doesn't increase symptoms for more than an hour after they do the activity, then that is considered sub-symptom threshold. Again, this is hard to kind of define when you're not really with the patients, but that's why we talk about this. And this is what we recommend kind of having athletic trainers and coaches know and families know, especially for some of the younger kids that don't have as much coaching support or athletic training support. There is significant evidence of increasing activity early actually decreases the length of the concussion. And again, back to what I was saying, increasing activity, but not contact activity until they're cleared. The other update, it's not necessarily just with rest, but if a patient has sleep difficulties about 10 days after concussion, then there are increased risk factors for prolonged symptoms. And so that's kind of another criteria to consider sending them to concussion clinic as well. And then back to what I was saying before on the SCOT, if there is neck pain for greater than 10 days or dizziness or headaches, the recommendation at this point is to start physical therapy, or if there's persistent symptoms at 4 weeks. And I feel like that's a bigger subset of patients than may have been recommended physical therapy in the past. And so I wanted that to kind of be put on your radar as well. And if they are, unfortunately, your patients have to go to Rady's, I would consider putting a referral in at their first visit if there's any neck pain or dizziness, or if they have any risk factors, just because of the length of time it takes to get into us. Or consider kind of any of the outside places that can see concussion patients. I just wanted to go over they kind of consolidated a little bit more of the return to learn into 4 steps, but starting with some mental activity that don't make symptoms worse. And so that's like trying to start with reading at home, and kind of increase gradually, starting with some school activities and then increase gradually. And then returning to school part-time, especially if they're still having a lot of symptoms, and then working on returning to school full-time. Just a reminder with when I'm talking return to learn, just this is kind of the same recommendations as the past. Considering a family in a school meeting, especially for your older teens that are in high school that are getting behind. Considering a 504 if symptoms are over 3 weeks, an IEP for symptoms over 2 months. And then if you feel like they're having significant cognitive changes, we could also refer to neuropsychology testing. Unfortunately, it can only be done if they are referred through rehab or neurology. And so I would recommend that you refer to the concussion clinic if you think that they need a neuropsych testing based on their concussion symptoms. I just put some things for a return to activity that is just a quick one. If patients have difficulty with symptoms, kind of significant symptoms, kind of limit physical activity in the beginning. If their symptoms are improving, continue to walk during PE. In the meantime, I would consider having them do a little bit more activity at home. But I feel like when you're kind of allowing them to do things in PE, it's kind of hard to have that ability to control if they're doing sub-symptom threshold or having to do whatever is happening in PE. And then as their symptoms improve, you could progress to allowing them to do non-contact activity in PE, nothing that they could hit their head again. And then when they're asymptomatic, of course, that's when they can return to full contact. Just some kind of reminders, if patients are having prolonged symptoms and they haven't started activity, remind them that increasing activity can actually help their symptoms. And then back to what I was saying, no full contact until their balance is normal and they're at their pre-concussion baseline, cognitively and physically. That's important for our patients that have chronic headaches or chronic pain, recognizing if they're at their baseline, they're likely to be kind of at a point where they can be cleared for their concussion, recognizing that their baseline sometimes may not be perfect as well. Just some last items. I wanted to go over some of the data that came out of this most recent update. Because of the concern for CTE and cognitive concerns and neurologic concerns for patients that are getting multiple concussions. So the data shows that there was no increased risk for amateur athletes for depression, suicidality, cognitive impairment, or neurologic disorders. There was also no increased risk for professional soccer players for increased psychiatric hospitalizations. And former professional football and soccer players were not at increased risk for psychiatric disorder or suicide compared to the normal population. But I thought it was really important to bring up is that professional American football players and soccer players both have an increased rate of neurologic diseases, dementia, including ALS. So when you're counseling, I mean, it is to the professional level. You're not seeing professional athletes because they're not professionals yet. But it kind of, I just give some of this data in my counseling to families because if they are trying to become professional athletes and they've had multiple concussions, it's important to kind of let them make those decisions. And that goes back to like when to take a patient or a player out of their sport. I think it's a family, multidisciplinary kind of, if you're, can talk to the coach, school nurse, kind of what's going on discussion. If a patient does decide to retire from their sport, the encouragement of continuing physical activity, either non-contact or low contact, especially if these patients are still having pain, in my chronic pain hat, is important. And so I usually, when I have this conversation with families, I usually say like, I can clear you to be able to be ready. I can tell you if you're still having all of this pain or these difficulties, you're probably not ready to do this sport. But I also know that being active and staying active is really important for your health. And so we start having a conversation that way. And that's where I open it up to family to tell me what they're confident in, what they feel comfortable in, and the patient to tell me what they're confident and comfortable in as well. Just our phone number in case you have a referral for us, and then some of our references. And I apologize for all the technical difficulties.
Thank you so much, Dr. Dalal. That was great. I am going to, first of all, thanks to all of our participants for staying with us so far. We appreciate your time. I'm just going to share my screen, and we're going to shift gears to talking a little bit about crazy sports nutrition. So let me just get the party started here. Is everybody able to see this? Okay. Cool. I'm going to assume that's a yes. So I wanted to cover a few different elements with this topic. I wanted to talk a little bit, first of all, about just making sure that athletes are actually taking in enough energy to fuel not only their sport, but their underlying just basic physiologic needs, and then the added energy they have to budget for to account for the huge increase in growth and development that's happening during your adolescent years. We're going to spend some time talking about appearance and performance enhancing drugs and what's new and interesting there. And I feel like, you know, I want to make sure that we're talking about the things that are actually recommended. So when you have athletes that are coming to you and saying, tell me the best protein powder to use, tell me whether creatine is okay for me to use or not. And I mean, it's great, first of all, that they feel comfortable enough to actually raise those questions with you. And it's a great opportunity to not only encourage them to steer clear of things that might be unnecessary or unsafe, but also to give them a viable alternative. So I'm hoping to actually provide some basic talking points as like a takeaway for several common nutritional issues that come up, so that, you know, hopefully that'll make it easier to work into your anticipatory guidance when you're doing pre-participation sports exams or just well visits in general. So let's start by talking a little bit about just straight up energy availability. And that very simply is the total amount of energy that you take in a day, like from all the nutrition and beverages that you consume, minus how much energy you spend on exercise. And what's left, as you can imagine, is what's available to your body for basic functions, but also in teenagers for growth and development. And if you have an inadequate energy availability, then not only is your athletic performance going to be impaired, but you're likely to experience physiologic impairment of various kinds. And those are the medical complications you see in patients with eating disorders and malnutrition, or malnutrition for really any reason. So one thing that I think is really important to counsel all young people about, we want young people to be active, but an analogy that I often use with kids is to think a little bit about budgeting with money, and that your body is really, really responsible in the way it budgets its energy. So the amount of energy you take in is almost like the amount of money you make, but then you have to be careful about your spending. So exercise is taking a huge chunk out of your energy budget. And your body considers things like your heart rate, your body temperature, your, just basic vital functions as really key expenses, like your rent. But then if it doesn't have enough money left over to pay for the luxury items like growing taller or going through puberty or having periods or even like mental clarity, then it's not going to spend money on that. And those are the first things that are going to ask, right? Like if your budget is tight, the luxury items are the ones that you're usually going to get rid of first if you're being responsible with your money. And that's what your body does too. And if it gets to the point that your basic vital functions are compromised, and that's when your body is even struggling to pay the rent, right? So I think that conceptualization can be helpful for kids. And so if you have an athlete who has low energy availability, you get this situation that is now in the literature referred to as relative energy deficiency in sport, or RED-S for short. I think many of us have heard of the female athletic triad, and that's a term that's generally not used anymore because, first of all, it's not just a triad. It's not just the traditional concerns about menstrual function and bone health, but it's also talking about other impairments in endocrine function, like thyroid deficiency, growth hormone resistance, impaired cardiovascular status, like decreased blood pressure, bradycardia, orthostasis, impaired gastrointestinal function, like delayed gastric emptying, slowed intestinal motility, hematologic side effects like neutropenia, anemia, obviously impairment of growth and development, psychological challenges and increased difficulty with regulating mood and emotion, decreased immunity, and reduced metabolic rate. So we are no longer calling it a triad because there's so many more physiologic functions that can be impaired. And we don't call it female because it can affect anyone of any sex or gender. So that's why the term was changed. And so not only is there a lot of evidence that having reduced energy availability, or this RED-S syndrome, leads to poor performance, but then obviously there's a lot of compromise with your health. And so one thing that comes up a lot is, should I call it RED-S or should I call it an eating disorder? Because there's, as we all know, a lot of eating disorder patients who will present with really, quote unquote, clean eating and excessive amounts of exercise. And in the Venn diagram between RED-S and eating disorders, the physiologic effects and the idea that they have reduced energy availability, I mean, that they both will often have that in common. I think that what separates them is more what's happening up here in terms of your psychological or emotional state. So with an eating disorder, there is a link to poor body image, and there's actually disordered eating behaviors like restriction or binging or fasting or food avoidance in, like, maybe not an intentional way, but there is still kind of a fear of introducing those foods. With something that somebody has purely RED-S and no eating disorder, then it's almost like an accident. They're not actively restricting their calories. There's no body image problem. It's just that the degree of their exercise just exceeds the amount of energy that they're taking in. So as you can imagine, the overlap between RED-S and eating disorders is actually very, very large. And I would say, personally speaking, and I would say also, like, in consultation with other members of my field, it is very, very uncommon for athletes with poor energy availability to purely have RED-S and not have an eating disorder as well. So, I think when it comes to distinguishing between the two, RED-S does not include like a mental health component, whereas eating disorders do. And I think that there's sometimes a tendency to diagnose people with RED-S instead of an eating disorder because there might be stigma associated with having a mental health diagnosis. But as we all know, if you don't identify that there is a mental health component to what's going on and you're not providing treatment for that component of what's going on, then that person's not going to get better. And their prognosis is going to be worse because early intervention for the psychological component is really key to both physical and psychological recovery. So if you think there is a mental health component to what's going on, my strong recommendation would be call it an eating disorder. It's not really doing the patient any favors to call it RED-S if that's not really what's happening. The other thing that I think is important to mention is, in the athletic community, there's a lot of things that are common and are often accepted as normal because they're common. For example, loss of menses. And I think it's extremely important for us as medical providers to say, just because it's common in like athletic circles does not mean it is normal. I have actually had patients tell me that their coaches would tell them that if they still had their periods, like they weren't working hard enough. So there's a lot of cultural, perceptions of those kinds of things that I think we need to provide some, we need to help to fact check those things. I And the last thing I would make is, you know, a lot of people say, well, maybe you just need to see a sports nutritionist or a sports dietitian. And while I would be the first to say that a dietitian can be enormously, enormously helpful in kids who have either red S or eating disorders, I think we need to stop perpetuating this myth that athletes somehow have different basic physiologic needs than people who are not athletes. So, for example, in my eating disorder work, I will often have people come to me and say, well, isn't their heart rate low because they're an athlete? Well, it's not normal to have reduced cardiac output. So if you have reduced cardiac output and low blood pressure and orthostasis and poor perfusion, that's not athletic heart, that's just physiologic compromise. Or, you know, because I'm an athlete, I need protein powder, or I need like much more protein than the average person. And the truth is that that may not actually be the case. When it comes to basic functioning, even athletes should have relatively normal heart rates. They should have normal pubertal development and regular periods and all the rest. So I think that we have to kind of create that that frame for our student athletes. All right, so we're going to get into appearance and performance enhancing drugs. This was incredibly fun for me to research. Just sidebar, it was really, really interesting and kind of scary. So a little bit of just general information about appearance and performance enhancing drugs in teenagers. There is a very, very, very strong association just in general with their use and eating disorder thoughts and behaviors. One thing that I thought was really interesting is that the more supplements that are used, the stronger the association with eating disorders. So if you're using protein powder and creatine and BCAAs and, you know, goodness knows what else, then your odds of eating disorder developments later on get incrementally higher. The other thing that I thought was kind of scary is that in teenagers, using these supplements and drugs is prospectively associated with more intolerance of your appearance and muscle dysmorphia. So in other words, if I'm a person as a kid who starts using things like creatine when I'm at a vulnerable age, I'm more likely later in my life to have body dissatisfaction. So I think that aside from like physical risks, we need to be thinking about like the psychological risks of using these kinds of products. And, you know, when we look at the prevalence of supplementation among athletes, it ranges anywhere from about 40 to 90%. And it's much more common in elite athletes and also athletes that are on the older side. And this is a quote that I took from the Academy of Nutrition and Dietetics guideline on sports nutrition, that supplementation practices among athletes are often guided by family, friends, teammates, coaches, the internet, and retailers, rather than sports dietitians and other sports science professionals, which I think we just know anecdotally to be the case. So let's talk about some of these drugs. And, you know, I think that in my head, a lot of us will, you know, I certainly did, will jump to like anabolic steroids when we think about these drugs. But the most commonly used one is actually caffeine. And the fact is, it actually does work. It increases muscle performance and it improves, you know, awakeness and alertness and focus. But they tend to have some pretty terrible side effects, like dehydrating you, exacerbating feelings of anxiety, impairing your sleep, making your heart rate too fast and potentially actually causing cardiac arrhythmia and upsetting your stomach. And one, you know, quote that I found in an article that I thought was really interesting is that while physically there might, in theory, be some benefit to using caffeine, it can actually negatively affect your ability to focus on tactical and strategic aspects of performance. So it might actually reduce your accuracy and reduce your functioning in team sports in particular. Because it's not just about like how well your muscles work, it's also about your ability to think, especially when you're playing a team sport. The other thing I thought was interesting is that for caffeine to actually help you, the optimal dose is at least 6 milligrams per kilo. So if you're talking about a 70 kilogram athlete, that's between 4 and 5 cups of coffee. And you know, the Academy of Child and Adolescent Psychiatry recommends a max of 100 milligrams of caffeine, which is about 1 cup of coffee per day for children and adolescents, purely from a mental health and sleep standpoint, like not even talking about like physical health effects. So caffeine is like not a great idea. One of the things that's also scary about caffeine is that young people aren't necessarily drinking coffee, they're drinking energy drinks. One study found that NCAA athletes, energy drink consumption is as common as protein powder use. And so nearly half the athletes that they surveyed were using it. And it's particularly increasing quickly among female athletes. One study that I just found like terrifying is the Mayo Clinic did a study looking at people who had survived a sudden cardiac arrhythmia and referred to their clinic. And 5% of them had consumed an energy drink shortly beforehand. And then after they stopped using energy drinks, nobody had another event. That's terrifying. So, talk to your patients about this study when you're talking to them about energy drinks. Similar to caffeine is the use of stimulants. So things like Adderall and Ritalin and related compounds. And it's used for similar, reasons that caffeine is used, because it increases your alertness. It permits you to exercise for longer because you feel like you have more energy. It actually does improve performance. But obviously the cardiovascular effects, like tachycardia, palpitations, potentially arrhythmia, more serious outcomes if you had an underlying cardiac condition that you didn't know about, are really scary and important to warn young people about. So when I am thinking about like talking points, like if you discover that you have a patient who's using caffeine or is asking you about using caffeine, the way that I would probably counsel them about it is to say like they do technically work to make you more alert, and they probably improve muscle function in the short term, but they can be extremely dangerous or even fatal for your heart. Tons of side effects that interfere with your performance, and you have to consume a lot of it to get the effect. So it's very likely you're going to have those problematic side effects. So I do not recommend them. All right, let's talk about protein powders and shakes, which have somehow become a food group in our society. So just in teenagers in general, we're not even talking about athletes. More than half of males and a third of females use protein powder just in their everyday life. And I think that it's advertised heavily as, a convenient way to meet your protein needs, which are often like grossly overestimated, and also to increase muscularity. One thing that I thought was really interesting is that teenagers who use protein powder are more likely to subsequently use anabolic steroids. So again, talking about how just engaging with these products can affect you psychologically and take you down a not so great path. And when we actually talk about what your real protein needs are, even if you are an athlete, it's about 1.2 to a maximum 2 milligrams per kilo per day. So just to put that in perspective, sorry, I'm just going to skip around a little bit. These are some natural foods and the amounts of protein that they contain. So just like a glass of milk has 8 grams, 4 ounces of chicken has 35 grams, 4 ounces of salmon has 30 grams, 6 ounces of Greek yogurt has 15 grams, cheese, peanut butter, eggs, they all contain a lot of protein. So if you, again, I'm just making up a number, if you're a 60-kilo athlete and you need a maximum of 2 mg per kilo per day or 120 grams of protein, you can easily do this with natural foods. So I think that pointing that out to patients and to say, you don't need all that expensive protein powder, it's kind of unnecessary, is an important thing to point out. And protein powders have a lot of problems with them. First of all, they are highly ultra processed, which more and more data is coming out to show that ultra processed foods have a lot of long-term adverse health effects. Because when things are made with soy protein, pea protein, whey protein, it's not like they just grind up peas and put it in the powder. They are extracting the protein chemically from that substance. So it's actually quite unnatural and carries all that risk of being like very ultra processed. It tends to be high in additives because otherwise it would taste super gross. So they tend to have artificial flavorings and sugars and sweeteners and sodium to make them taste better. It tends to give you way more protein than you actually need. And if you happen to have impaired kidney function, it's going to put a lot of stress on those kidneys. And if your kidneys are functional, then you're just going to pee a lot of it out. And then the other piece is that much protein in the absence of other macronutrients to balance them out will often cause stomach upset. To me, one of the scariest things is that protein powders are not classified by the FDA as a food. They are classified as a supplement, which means that they are not subject to the safety regulations and safety standards that would be applied to foods. So it is a wild, wild west, highly unregulated industry, and protein powders are very commonly adulterated with unlisted ingredients. And there's three really common ones: heavy metals, anabolic androgenic steroids and related compounds, and stimulant or caffeine related substances. So that's all like pretty bad news bears. And this was a really interesting study that came out a few years ago that summarized the number of top selling protein powders that were just tested to find out what is actually in these powders. And they were highly, highly likely to be contaminated with arsenic, cadmium, or lead, highly likely to have elevated levels of BPA. Organic products, quote unquote, organic products are actually more likely to have heavy metals. And plant-based products were significantly more likely to have heavy metals, with 75% of the samples testing positive for lead. So that is pretty terrifying. And so again, when it comes to talking points about protein powder, they're really highly processed. They have lots of additives. They're not actually considered food, so they have a very high contamination rate, and it's way better to get your protein from your real natural foods, much less expensive and not that hard to do. And there's some evidence that protein powder is a gateway to subsequent steroid use. All right, I want to talk a little bit about branched chain amino acids. All the kids are talking about BCAAs, branched chain aminos. How do I get more branched chain aminos? And it's basically just a more expensive protein powder that you can buy that only contains 3 amino acids: leucine, isoleucine, and valine. And they are essential amino acids in that you must get them from your diet. Your body doesn't produce them naturally. So one of the reasons that they have gotten so sexy is because, unlike other amino acids, they seem to bypass your liver and are metabolized directly in the skeletal muscle. And the idea is, at least in theory, that metabolic process activates signals that in theory would stimulate muscle protein synthesis. In reality, it doesn't actually do very much. The effects on muscularity, body composition, and performance are negligible. So tell people to save their money and to get these amino acids from foods naturally, because dairy products as well as natural proteins tend to be very high in these amino acids anyway. And it's probably in a much more usable and safe form if you just get it from food. Creatine. All right, I feel like this is one of the things that we're probably seeing more and more often. This is the most commonly used supplement, aside from like protein powders, in athletes. Like about 1/3 of college athletes, up to 40% of high school senior athletes. And it's touted as something that will increase muscularity and performance. And one of the things that was fascinating is that the way creatine works is it increases water retention within the muscle tissue. So your weight increases and your muscles can appear, based on measurements, sometimes up to 10 to 20% larger just from water retention. So it doesn't actually increase your performance. It might have marginal, but statistically significant, but extremely minimal improvements in performance in fast twitch muscle sports, so like sprinting, short distance swimming. It may potentially help a tiny, 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 tiny bit, but there's absolutely no long-term benefit, either in performance or in muscle strain. And actually in endurance sports and like long distance sports, it can actually impair muscle function. It's not necessarily acutely toxic unless you have underlying renal disease, and then that can be pretty harsh on your kidneys. But I think one of the things that's important in adolescents in particular is teenagers are supposed to be increasing, particularly people who are assigned male at birth, increasing their lean muscle mass over the course of their pubertal years. And there's some concern that chronically increasing water retention in your muscles is not safe during puberty when muscle mass is developing. So to me, that's a really key point. And aside from that, there just have not been a lot of studies that are either A, long-term, or B, done in, kids and teenagers specifically. So my talking points for teenagers are increasing water in your muscles doesn't actually increase your muscle mass. It can make them look a little bit bigger, but it's really just retaining water. And that might not be safe in your teen years when your muscles are growing and developing. It can put strain on your kidneys, and it really doesn't help with athletic performance. Anabolic steroids. I'm not going to spend too much time on anabolic steroids just because I think we all know they're bad. And I think there's a lot of stuff that we already know about the bad systemic effects they can have throughout a person's body and psychiatrically. But I did want to mention some steroid adjacent supplements that are actually pretty popular. So the medications androstenedione, which is commonly referred to as andro among athletes, and human growth hormone, often referred to as HGH, are legally obtainable if they're prescribed by a physician. I discovered, though, in researching for this project, that it is surprisingly easy to buy injected human growth hormone online. I didn't give them my credit card number, but it was actually like weirdly, concerningly easy to do. But actually, one of the ones that I was surprised to learn about is that DHEA, or dehydroepiandrostenedione, can actually be put in a bottle and is considered a dietary supplement rather than an anabolic steroid, unlike the rest of the world, which just considers it an anabolic steroid. So in the US, DHEA is actually the most common anabolic agent available in dietary supplements, and it's legal and it's pretty easy to buy, and you can just buy it off the shelf in like a health food store. But it is still considered a banned substance by the World Anti-Doping Agency. So still not a good idea to be using. Okay, so a lot of doom and gloom about what not to use, and I want to come to, so what should I do then? If I can't use protein powder and creatine, then how can I make myself, strong and a good performer? This is what it comes down to. And this is a summary of a really great position paper by the Academy of Nutrition and Dietetics. And this is just a summary version. Number one, you need carbs. You need carbs that are both simple and carbs that are complex. And you need it to provide immediately usable energy because they are the most efficient source of ATP. But you also need to top up your glycogen stores and then replace them while you're exercising. There's also some evidence that the mouthfeel of carbohydrates has a positive neurological or cognitive effect on your brain that makes your body perform better. Translation, carbs make us happy. And when we're happy, we can perform better. So cutting out carbs is not a good idea. The other piece is, despite all the emphasis there is on like protein is only useful for muscle synthesis and recovery. And if you eat a lot of protein, but you don't eat a lot of carbohydrates, then your body doesn't have that carbohydrate intake available for immediate energy. So it's going to use the protein instead. It's just going to break it down to try to release some ATP, and it's not going to go to your muscles. You're not going to actually become muscular if you are eating protein without carbs. Fats are the least efficient energy source. They contain a lot of energy, but it's the most work for your body to break down. But you still need fats in your diet because there are essential fatty acids and fat-soluble vitamins that you're not going to get any other way. And micronutrient supplementation, like iron supplementation, calcium supplementation, is almost never necessary for athletes unless they actually have an identified deficiency, like on their lab work. And I think the other piece that's really important is micronutrient deficiency does not occur in athletes unless they're not getting enough calories. Because one thing I think is interesting is that there's 6 milligrams of iron in every 1,000 calories of nutrition consumed, assuming that it's like a reasonably variable diet. So in athletes, if they're iron deficient, strongly suspect either like completely missing food groups like veganism or vegetarianism, or just inadequate calories. On top of this, your total energy availability, as we talked about, needs to be sufficient to fuel not only your exercise, but your basic functions and your growth, and you need fluids in the background. I would also say that the timing really matters. So before exercise, you want to be getting your complex carbohydrates to build up your glycogen stores, pre-hydrating foods that are maybe a little lower in fat just to avoid GI side effects and cramping and stuff like that while you're active. And you don't need to protein load, but you just need like normal amounts of protein throughout the day. And then during exercise, you need an ongoing source of carbohydrates, both complex and simple, in the neighborhood of 30 to 90 grams an hour to top up your glycogen, give you some blood glucose, and again, the positive CNS effects, while replacing fluids and sodium that you lose from sweat. Then after exercise, you need more carbohydrates to replace the glycogen you've used up. This is where protein becomes more important for muscle recovery. Hydration, and I don't recommend like weighing athletes routinely, but it can be helpful to weigh athletes before and after exercise to get a sense of how much fluid they lose with activity. So it gives them a target to aim for. And this is a good time for fat consumption if you're not going to be like immediately exercising afterwards. So you don't need any of this stuff. And any kind of exclusionary diet is not likely to help you. But this is one quote that I want to end with that I just thought was really, really nice and like a good message, is that the necessary components for success in athletics extend beyond physical characteristics and likely include a combination of physical and mental attributes as well as training and persistence. So with that, I'm gonna close out and move on to our Q&A, but thank you so much for your attention. Thanks so much to Dr. Spitzer and Dr. Dalal for their presentations as well, and we're looking forward to having some discussion. So people can feel free to just like shout things out, like unmute yourself and feel free to talk, or if you want to put questions into the chat, whatever you're most comfortable with, please feel free.
Hi, this is Mike Nelson. I'm a general pediatrician with Kaiser Permanente and the proud husband of Dr. Marcia Spitzer. Excellent presentations. I do have to full disclosure. I am closely related to one of the speakers tonight. Dr. Kumar, I had a couple of questions for you. Can you hear me?
Go for it. Go for it.
Okay. So first of all, I wanted to clarify, when you'd mentioned the adverse effects of stimulant medicine with athletes. I assume that you also implied that those are when those stimulant medicines are abused, not when they're used to radiate.
100%. So if somebody is using prescribed quantities of stimulant medication for the purposes of ADHD treatment, and they have had, that implies they've had the necessary like screening about, they've had a physical exam, their family history has been looked at, this person has been pre-screened to determine like this is a good candidate for stimulant medication treatment, and it's being monitored to make sure that they're tolerating it appropriately, then that's fine. And I think it's very relevant because I mean that was a whole controversy about like Simone Biles recently, right? So she was accused of using stimulant medication for athletic performance, but I mean I'm a little fuzzy on the details, but my understanding is she'd been prescribed ADHD medication, in stimulant form since she was a kid, and she was just taking her prescribed dose. So I guess it's a little controversial, but because you'd have to be really, documenting that this is a person who neuropsychiatrically benefits from stimulant medication. But I'm talking more about like a diversion kind of situation where people are using it without being medically cleared to use it, and in inappropriate like times, doses, that kind of stuff.
Okay, thank you for clarifying. Second question was, are you seeing any talk about the use of beets as a performance? Yes, beets and beet chews, and as I think it's nitric oxide that it improves as a performance enhancing.
I wouldn't be surprised. I mean, because I feel like people can come up with almost anything, and I guess like, if you want to eat a beet, like go for it, right? But I guess the question is, are you eating beets at the expense of other things? Because I think that that's really what's more problematic. Like a lot of the fad diets that you see, and I think this is like actually a really good like general point, is like teaching young people how to detect what is probably a fad diet. Any diet that tells you to eat a whole lot of something or to exclude something completely is probably not scientifically accurate and probably has dangers associated with it. So I imagine there's like a beet diet where you're supposed to eat like 10 beets for every meal. And it probably also has a list of things you're supposed to avoid. That would not surprise me at all. That's like very formulaic, you know. And then tomorrow it'll be a turnip diet. And like next year it'll be whatever, a purple cauliflower diet. I don't know. But like, those are the same, the essential qualities are, is it telling you to eat a whole lot of something and then not like to strictly avoid other things? Because if so, kind of fits that formula of like not being real, not being a good idea.
Great, thank you.
Yeah.
And then Dr. Dalal, am I pronouncing your name correctly?
Yep.
Yeah, thank you very much for your presentation. I actually have a close personal experience with recovering from a pretty significant concussion and brain injury. So your points are well taken. So thank you both.
I'm
And Dr.
sorry.
Spitzer, thank you for your excellent presentation this evening.
All right, I'm muting him now. Okay.
We do have a question in the chat from Dr. Gibbons. Are there recommendations for protein intake during injury and recovery? That is a very good question. The protein recommendations do increase somewhat in the case of an injured athlete. But at the same time, you know, depending on the nature of their injury, their expenditure might also be less. So at the end of the day, it typically balances out. Because you're not having as much muscle breakdown with like, you know, with physical activity because you're injured. And it's still in the neighborhood of like between 2 and 2.5 milligrams per kilo per day versus like 1.2 to 2. So it's not that much of a difference. And it still wouldn't necessitate like protein powder intake or something like that. But that's a great question. Other thoughts, comments? Would anyone like to share their own wild and wacky just stories from doing sports physicals or evaluations?
If anyone
I
wanted
literally
to
just had
talk,
a
we would.
patient ask about this. So thanks for sharing the creatine information.
Creatine. I guess if there's no questions, then thank you all for sticking it out with us. It was great to have everybody here. This presentation's been recorded if you want to refer back to it or share it with your colleagues. We just put up the link for the CME survey. So please feel free to fill that out to get your 1.5 CME credits. And thank you all so much. Oh, another announcement. Registration is open for the upcoming school health conference. So y'all want to get on that. Thank you guys so much and have a lovely evening. Thank you so much, Dr. Dalal and Dr. Spitzer for participating in this presentation. It was awesome. I learned a lot.